Senior Research Fellow here at Bangor University, and her research is on reducing the health inequalities for people with severe mental ill health. Thank you very much, Emily, for joining us.
Thank you. Just share my screen. Okay, so my name is Emily Peckham. I'm going to talk to you today about oral health and mental ill health, and talk about some of the inequalities and barriers that people with mental ill health experience in terms of their oral health and some potential solutions. So this work that I'm going to talk about today comprises various pieces of work that I've undertaken with colleagues in different universities. So to tell you a little bit about what I'm going to talk about. So first of all, I'll just give you a bit of background around oral health and the challenges that people with severe mental illness experience around oral health. Then I'll talk a bit about a consensus statement that some colleagues developed on what people with severe mental illness should expect from their oral health. Then I'll talk about a study that I'm currently working on. I'm the co-chief investigator with a colleague from University College London, and that's called the SMILE study. And then I'll just talk a little bit about what the next plans are for this work on oral health. So just a bit of background. So people with severe mental ill health, and by people with severe mental ill health, I'm talking about people with schizophrenia, schizoaffective disorder and bipolar disorder. So there's no one definition of what comprises severe mental ill health, but all the work that I've done is uses the definition of people that would typically be on primary care severe mental illness, severe mental health register. So that's people with schizophrenia, schizoaffective disorder or bipolar disorder. So the work that I'm going to talk about today, that's the definition that we've used, although, you know, there's not a standard definition and different people will use different diagnoses and different terminology. So people with SMI on average die 15 to 20 years prematurely. So that's 15 to 20 years before people without this diagnosis. And over 70% of these deaths are attributable to preventable physical health conditions. So often it's not due to people's mental health, it's due to a physical health condition that could have been prevented. And oral health is one of the physical health conditions that are contributing to these early deaths. And we know that oral health among people with SMI is poorer than that of the general population. So I'm just going to give just a brief bit of background around oral health and what is oral health and what we're talking about in terms of this presentation and this work. So oral health refers to the overall condition of mouth, teeth, gums and related structure. It plays a vital role in the ability to eat, speak, breathe, as well as affecting confidence and well-being. So good oral health is essential in helping to avoid and manage conditions such as tooth decay, gum disease and infections. And risks to good oral health can include poor dental care, smoking tobacco, drinking alcohol and eating foods that contain high sugar. So it's really important to maintain your oral health. Why is this? It's important because it affects the whole body, not just the teeth. So, you know, common to some people's misconceptions, it's not just the teeth if people have poor oral health, it's the whole body that can be affected. And good oral health can help prevent pain and disease. It can protect overall health. And it can also importantly support eating and speaking without discomfort. In some of the work that we've done around people with severe mental illness, people have talked to us about feeling uncomfortable eating in public because of their teeth, or people feeling uncomfortable speaking in public and going out in public and socialising because of their teeth. And that's really important to people and really causing a significant amount of difficulties within their everyday lives if they didn't feel comfortable eating or speaking around people or without discomfort. It can also, you know, because of this, it can maintain or improve people's self-confidence. If people have got a good oral health and they're confident with their teeth, then they can feel more confident. But equally, if they're not confident, then that can lead to a lack of confidence. And it can also save money in the long run. Having to have a lot of dental work done can be quite costly. So that's why it's important. Oral health in people with SMI is likely to be worse than people without this diagnosis. So people with SMI experience higher rates of tooth decay than those without SMI. They're 3 times more likely to lose all their teeth. That's all their teeth, not just some of their teeth. They're less likely to visit a dentist for routine dental checkups or treatment. And the reasons for this are that mental health can lead to people being less motivated to brush their teeth regularly. People can feel a lack of motivation. Sometimes the side effects of medication can lead to people feeling less motivated. Sometimes it's the mental health condition that people are living with that can lead to them feeling less motivated, feeling more tired, more lethargic. And sometimes people can just forget to brush their teeth. Um, so um, so the higher rates of tooth decay can be associated with lack of toothbrushing. They can also be caused by poor diet. So people with SMI typically have a lower income than other groups of people, and that can lead to an inability to buy or afford more nutritious food, and can lead to people eating diets high in sugary content. Drinking also, people may tend to drink a lot of the energy type drinks that are high in sugar as well. So it's not just the food they eat, but what people drink as well. You know, a lot of sugary energy drinks or sugary fizzy beverages, things like that. There are also things like the side effects of medication. So some of the medications that people take for their mental health can lead to a dry mouth. And again, having a dry mouth can lead to poorer oral health. One of the other things is people with SMI are more likely to smoke than people without. So compared to the general population, where about 14% of people smoke, depending on where the people are residing, so people who are seen in secondary care mental health services, around 45% of people will smoke. So they can see that that's a big difference, and that can also lead to poor oral health, the smoking, and also consuming alcohol. And it can have a big impact on people's overall health and well-being. Untreated decay is a common reason for hospital admissions. So for people with SMI, that's one of the common reasons that people are admitted to hospital, is due to poor oral health and having to have some emergency dental health treatment. And that also is compounded if people aren't visiting the dentist because they're not able to visit a dentist because of lack of availability of NHS dentists, or lack of knowledge about how to access NH dentists. That can, impact on the situation if people aren't able to go to the dentist and receive treatment. That's makes it all the more difficult for people to maintain their oral health. So there are multifaceted reasons why oral health in people with SMI is likely to be worse than people without this diagnosis, and why something needs to be done to support people to improve their oral health. Poor oral health is also linked to other cardiovascular diseases and things like that. So it's really important that people are supported with their oral health. And cardiovascular disease is one of the main physical health conditions, along with diabetes, that people with SMI experience and are contributing to the reduced mortality that people experience. So what can we do about these? So one of the things that I did in 2020, when at the time I was working on a project that was set up it was a mental health project that was set up to create a group of researchers who were interested in improving the physical health of people with severe mental illness. So whilst doing that piece of work, I realised that there were quite a lot of people who were interested in the oral health and dental health of people with SMI. And there were a number of researchers working in this area, but everybody was working separately and on different projects, and there was no joined up working between us. So me and a colleague who is a carer for a daughter with schizophrenia, set up an oral health special interest group. And we invited people to come to the special interest group, and we had a discussion about what we thought that we should do and what we could do to support people with SMI with their oral health. And we decided that one of the first things that would be worth us doing was developing an oral health consensus statement. And the aim of the oral health consensus statement was really to come to a consensus on what we thought and what people with SMI thought they should expect in terms of their oral health. So to develop the oral health consensus statement, we set up an expert consensus group, and we invited people to join that group. We invited people with severe mental illness, with lived experience of severe mental illness. We invited informal carers, we invited dental health professionals and mental health professionals, and we invited policymakers. And once we'd got this group together, we then held a series of co-production workshops with the stakeholders. First of all, we spoke to people with SMI and their informal carers about the challenges that they experienced with their oral health, what the unique challenges people experienced, what were the difficulties, and what did they feel would be able to help them improve their oral health, what would help them visit a dentist, all those kinds of things. And we heard from people and discussed what their challenges were, what their barriers were. And we also spoke to dental health professionals about their experiences of working with people with severe mental illness and what challenges they'd experienced and what challenges they'd found that the people that they worked with had experienced. And we did the same for mental health professionals and with policymakers as well. So we held these series of co-production workshops, and together we then came up with some things that we felt that people, or the group felt, that people with SMI could expect in terms of their oral health. And so this on the left-hand side of the page, the right to smile, that's our consensus statement, and we called it the right to smile because we felt that everybody should have the right to smile, and no one should feel that they can't smile because they're embarrassed or concerned about their teeth. And our statement, no health without oral health for people experiencing severe mental ill health. So that's the front page of our consensus statement. And these are the sort of the things behind the consensus statement. So the consensus statement recognises the need for training of healthcare professionals, and that both mental health professionals and dental health professionals, because through the consensus work we realised that mental health professionals felt that they would benefit from understanding a bit more about oral health, and that dental health professionals felt they would benefit from understanding a bit more about mental health. So there was a need for training of both mental health and dental health care professionals in each other's specialisms, not so that they would become a specialist, but just having a bit more basic knowledge so that they could better support the people that were coming to them and the people in their care. We also recognised that there was need for research and evidence-based practices to guide oral health interventions. Currently, there's very little, or there was very little research to guide oral health interventions. And that was hoped that through the consensus statement, we could use the consensus statement to leverage funding for further research, to have research evidence interventions to support people and guide them with their oral health. And we also felt that there needed to be effective strategies, interventions and policies that can improve oral health outcomes in this population. So those were the kind of underpinning things that the statement recognises. And then, so in terms of what the consensus statements were, the consensus statements were that any assessment of physical health in people experiencing severe mental health must include a consideration of oral health. So currently, in some parts of the UK, that people with severe mental illness or severe mental health, it's expected that they have a review of their physical health annually. So they have an annual review of their physical health. Access to dental health services for people with severe mental health needs to improve. So access to dental services for the whole population are currently, the NHS services are currently under a lot of pressure, and with people with severe mental health being particularly disadvantaged and finding it particularly hard to access dental health services. And the importance of oral health for people experiencing severe mental health should be recognised in healthcare training systems and structures. So some of the things that we felt that come out of this were that health promotion advice about healthy eating, tobacco and substance use should initiate discussion around oral health, and it was important that that was taken into account and discussions were initiated. Carers should be made aware of the importance of oral health for those they support and given advice and information on how they can encourage good oral health. So it's really important that carers understand that as well. So that, you know, not just informal carers, but people who are providing carers, perhaps if someone's in an institution, such as a mental health institution or in supported living, that people are provided with the care and support to maintain their good oral hygiene that they need. And dental services must make reasonable adjustments to enable people experiencing severe mental health to attend and receive expected oral health care. And one of our aims was at least 60% of people experiencing severe mental ill health should receive regular dental checkups consistent with clinical guidelines around dental attendance in the general population. And it's important that dental services are commissioned to meet the local needs of vulnerable people, which includes those with severe mental ill health, emphasising equity and access to dental services. And people should be supported to claim free or subsidised treatment when they're eligible, because sometimes people felt when we develop the statement that they couldn't afford treatment, but they didn't realise that they were eligible for free or subsidised treatment. So it's important that people are supported to claim what they're entitled to. And we also felt that dental, medical and other undergraduate teaching curriculum should include the understanding and management of oral health problems for people experiencing severe mental health. So that's what the consensus statement said and what we were hoping to do. So what were the results? We've had the statement endorsed by various organisations, including the Royal College of General Practitioners and some dental health organisations as well. And oral health has now been included in the NHS England's recommendations for physical health checks in people with SMI. So in the list of what the physical health check should include for people with SMI, oral health is now mentioned where it wasn't mentioned before. Some of the colleagues in our oral health special interest group have developed training for undergraduates. So for undergraduate mental health programmes, they've developed training around oral health, and for undergraduate dental health training, they developed training around mental health. So that training's being developed currently with some of the colleagues that I've worked with. So that's really important as well. So hopefully going forwards, there'll be a greater awareness in mental health professionals and dental health professionals of each other's disciplines. We've also received research for patient benefit funding for the SMILE study, which I'll tell you a little bit more about in a minute. And that's a study looking at improving the oral health of people with SMI. And other countries around the world are developing similar consensus statements. So, for example, Australia, some colleagues in Australia who are part of our oral health special interest group are hoping to develop a similar consensus statement. And we've also got a colleague in America, in the US, who is also working around oral health and improving the oral health. So I think that's really important that we've managed to sort of not only disseminate the consensus statement within the UK, but hopefully spreading it more widely. So in terms of the SMILE study, so the SMILE study is, its full title is Enabling Service Users with Severe Mental Illness to Learn About and Engage with Good Oral Health, a feasibility and acceptability study of an intervention aimed at improving the oral health of people with severe mental ill health. So the SMILE study is funded by Research for Patient Benefit, and I'm the chief investigator with a colleague from UCL. And we're working in conjunction with Sheffield Health Partnership, University NHS Foundation Trust, and Tees Eskinweir Valley's NHS Foundation Trust to deliver this study. So this is a feasibility study. So we're just working with two NHS organisations at the moment. If it's found to be acceptable, then hopefully we'll be able to obtain funding to do a wider study, and then hopefully bring the study to Wales as well, and be able to involve people within Wales within this study. So just to give you a quick overview of the study. So the aim is to explore the acceptability and the feasibility of the SMILE intervention. So the first thing we had to do before we could explore the acceptability and feasibility of the intervention was create the intervention. And the intervention was co-produced. And I'll tell you a little bit more about the intervention after I've told you a bit about the study and the eligibility criteria and everything. So we created, as part of this Research for Patient Benefit grant, an oral health intervention for people with SMI. And that was co-produced with people with lived experience, carers, and mental health and dental health professionals. The study is a single-armed feasibility trial, so we're just offering everybody who's recruited to take part in the study the oral health intervention. The intervention takes about 30 minutes, 20 minutes providing oral health advice and support, and 10 minutes where toothbrush and a paste with instructions for how to brush your teeth is given to people. And the study participants in the study are followed up at 3 time points. A baseline assessment's conducted where they're asked about questions about themselves, about their oral health, their toothbrushing habits, consumption of sugary beverages, smoking, alcohol, that kind of thing. And then people are followed up 3 and 6 months afterwards to see whether their toothbrushing has increased. That's the primary outcome, is looking at toothbrushing, and whether they any changes in their diet, smoking, alcohol consumption as well. The primary outcome is the acceptability and feasibility of delivering the intervention. So we're really looking at, did people find the intervention acceptable, and was it feasible to deliver? So the eligibility criteria for people to take part in the study, it's a study for adults, so people aged 18 and over. People have to have a diagnosis of SMI. So for the purpose of this study, it's schizophrenia, schizoaffective disorder, bipolar disorder. So that's the SMI diagnosis that we're using for this study, and we're recruiting from the Tees Eskinweir Valleys and Sheffield Health Partnership. The exclusion criteria are if somebody's currently admitted to an acute psychiatric inpatient ward, they're not eligible for inclusion. So we're recruiting people who are living in the community. They can be living in supported living accommodations, so it's just people on the acute psychiatric inpatient ward, and people who lack capacity to participate in the study, and people who are unable to communicate in English. Because this is just a feasibility study, we didn't have the funds available to translate all our materials into another language for the larger scale trial, which we hoped to run. We would hope that we would be able to do that. But for the purpose of this study, that was one of our inclusion criteria. So the co-production of the SMILE intervention, we co-produced the intervention, and it was produced through 4 co-production workshops and through some public involvement meetings with service users as well. So the co-production workshops were with service users, carers, mental health and dental health professionals, and the public involvement meetings were just with service users and carers. And 2 of the service users who were members of the public involvement group also attended the co-production workshops, so that we had the information from the public involvement groups. We could ensure that was shared within the co-production workshops. And there were some service users who were just members of the co-production workshop, so that we could have an opportunity for people to attend it in the way that they felt able to attend, because we wanted to ensure that people could, as many people and as diverse a group of people could attend as possible. Because, for example, some people didn't feel comfortable attending co-production workshops, but were happy to be part of the public involvement group, and we wanted to ensure that their information and their thoughts and ideas and views were shared in the co-production workshops. So they were shared via the public involvement group members who attended the co-production workshops. So in the first workshops, we looked at the barriers and facilitators to maintaining oral health, and then we looked at some of the intervention components and worked through the intervention components, discussed them, how they would actually work in practice, who would deliver the component, and sort of then ended up with the finalised intervention. So as I already said, the intervention's a 20-minute to 30-minute face-to-face appointment, and it's an appointment with a mental health professional. So this intervention is delivered by a mental health professional, and the mental health professional will talk to the person about any oral health issues and discuss tips to improve their oral health. So it's a very brief, light touch intervention, this one. And it's just a hope to get a conversation going, get people talking about their oral health, raise awareness of oral health, and get people thinking about what they could do to maintain or improve their oral health. So in terms of what the intervention actually is, it has a few steps. So I don't know how well we can see the slide. Step one is offering people to have a conversation about their oral health. So in the feasibility study, it's likely because people have been recruited because they're interested in taking part that they're going to be interested in having a conversation about their oral health. But if this was delivered in practice, there would be a question about, would you be interested in discussing your oral health or talking about your oral health? So the consultation, a conversation about oral health will be initiated. And if somebody says no, then that's fine. There'd just be, say, if you do want a conversation in the future, then please do let me know. If you want to talk to a mental health professional, let us know. If they say yes, then the conversation is initiated and we work through the different steps of the intervention. If urgent treatment is required, then the person should be supported to receive any urgent care. And that's if somebody's in severe pain with any oral health problem, severe toothache or something like that, and they need to be urgently seen, go to A&E or something like that for an emergency appointment, then the person should be supported at that point to receive that. So the intervention basically is for people who don't need any urgent, really, really urgent care, when really urgent treatment. So if somebody is happy for the conversation, they don't need urgent treatment, then they would go through the different steps of the intervention. So they're given some hints and tips, which I'll talk about in a little bit more detail on the following slides. And then once they've received the hints and tips, they're given a toothbrush and paste and a demonstration of how to use the toothbrush and paste if they want it. And they're offered the option of being sent text reminders about brushing their teeth. So if somebody wants to have a text reminder, they can have a text reminder for up to 4 weeks to remind them to brush their teeth. If people felt that would be beneficial to them, then they're offered that. And the final step is to include the information in the person's care notes. So the mental health professional who's delivered the intervention will put in the person's care notes a brief summary of what they've discussed and if there's any follow-up that's recommended for that person. So that's the overall intervention. So initiating the conversation, it was felt that it was really important about how the conversation was initiated. So we did go into some detailed discussions in the co-production workshop about how this should be initiated. So things like, when did you last see a dentist? What was it for? Was it a routine visit? Was it an emergency visit? How do you feel about your teeth now? Something gentle, something that would encourage people to talk, and something that was open-ended and not stigmatizing. So hopefully those, we'll see from the intervention whether people found these openings acceptable to them. The next step is the tips, so giving people some tips. So I'll just give just a couple of the tips that we're giving. I'll just explain a couple of the tips. So we talk about recommending people that they brush their teeth twice a day. We discuss toothbrushing, and there's a diagram or a video that people can watch if they want to. And then people are given tailored advice based on their readiness and the barriers that they're experiencing to regular toothbrushing. So we've got these different levels of readiness. So if somebody's not brushing their teeth at all, we'd probably think that there was a low level of readiness. So they'd be encouraged to brush their teeth once daily, ideally at night, and then gradually increase. If somebody's brushing their teeth sometimes but not regularly, encouraging them to brush their teeth twice daily, discussing reminders like text reminder, or how people might be able to do a reminder for themselves, like setting an alarm, having a calendar, putting a toothbrush by their bed, and discussing any specific barriers that that person might experience. So, for example, somebody said their barrier that they experienced was they went to bed quite early, or they got into bed quite early, but they didn't go to sleep. So that's why there's an example of maybe having a toothbrush by your bed if somebody gets into bed quite early but doesn't go to sleep. And then people with high readiness, brushing their teeth twice daily, but not brushing their teeth before bed, encouraging them to continue with what they're doing, but advising them to brush at night, ideally before bed and on at least one other occasion. So you can see there was a tiered approach depending on people's readiness, really. And again, this was co-produced with people with lived experience as to what they felt would feel acceptable. One of the key things that some people experience in terms of a side effect of their medication is a dry mouth. So really recommending to people to sip water frequently to help with dry mouth. So rather than having a sugary beverage, drinking water instead of that if people are experiencing a dry mouth. So assessing the acceptability and feasibility of the intervention. So to ensure that we're assessing the feasibility and acceptability, we're recording the recruitment and follow-up rates. So people are being invited to take part in the study, and we're recording the number of people who are invited and then the number of people who agreed to take part, because that will give us a bit of an indication. And then we're looking at the follow-up rate. So how many people complete their 3-month and how many people complete their 6-month follow-up. And then we're also looking at the number of people who received the intervention. So we're aiming to recruit 30 people. And of those 30 people, we'll look at how many people who actually received the intervention, who agreed to actually have the intervention, and an appointment was made, and that they attended the appointment with the mental health professional. So all the 3 participants and all the people who delivered the intervention will be asked to complete a questionnaire. And that's just a short questionnaire asking them about how they felt about the intervention. And we'll use that again to assess the feasibility and acceptability. And one-to-one interviews will be undertaken with a subset of people who received the intervention and a subset of people who delivered the intervention. And that asks them for more detailed feedback about their experiences of the intervention. And together all this will determine whether or not people have found that the intervention to be acceptable and feasible. So whether the people who received the intervention, people with severe mental ill health, found the intervention acceptable to them, and whether the people, the mental health professionals delivering the intervention, found it feasible. So the next steps in terms of the this oral health work is we'll apply for a grant to deliver a full-scale trial to assess the clinical effectiveness and cost effectiveness of the SMILE intervention. And also hoping to explore the possibility of translating the consensus statement into Welsh and ensuring it fits within the Welsh context. So that's something that we'd really like to do as well. There's another study currently being undertaken around improving the oral health of people with SMI as well. And this study is looking at some colleagues in Lancaster University living, and that's looking at link workers supporting people with SMI to make an appointment with a dentist, to identify a dentist that's taking on NHS patients, and then to make and attend an appointment. So there's quite a bit of work now going on within this area as a result of the oral health consensus statement that we developed in 2020. So thank you everyone for listening. There's the NIHR disclaimer for the study and my email address. So I'll just stop sharing now.
Thanks very much, Emily. We don't have any comments at the moment in the chat, and we're a small enough group, so if anyone has any questions, please do just unmic.
Thanks, Emily. Nathan here.
Um,
I just wanted uh, really interesting work, and I think it's also really prescient with the news report today around an individual who had committed suicide because of some dentistry issues they'd had. And I just think it's a really challenging area. I wonder if you could talk a little bit more about engaging with people in a research capacity for people who might not necessarily normally engage in research because of the challenges they have in their lives. Are there particular things that you do in order to sort of encourage people to take part in this sort of research?
yeah, so with this study, so with the SMILE study, we've actually been quite pleased because it's recruited quite well. So the the co-production of the intervention took quite a bit longer than we anticipated, so the study got a bit delayed. But actually, the recruitment's gone really well, and people have been quite interested um, in receiving support from their oral health. So, in terms of engaging people in research, what we've done is ask mental health professionals, so mental health nurses, psychiatrists, healthy living advisors, just people who work within community mental health teams. To talk to people and ask them, we're doing this study of oral health, would you be interested in taking part? And actually, people have been really interested. So I think sometimes there's a misconception that
Mm,
people who are experiencing severe mental ill health aren't interested in research, and also aren't interested in improving their physical health, and including oral health within that. And I think it's just a common misperception, so people don't get offered things. So for
yeah.
example, a few years ago, quite a few years ago now, I worked on a smoking cessation study. And in that study, people said to me at the start of the study, you're never going to recruit people
Mm,
um, because people with severe mental illness are not going to be interested in doing anything about their smoking. And in that study, we had to recruit 400 people. We're supposed to recruit 400 people in 18 months, and we recruited 526 people in 16 months. So we
wow.
recruit, and trials hardly ever recruit ahead of target and ahead of
Yeah.
schedule. And I think that just shows that people are interested. It's just that it's approaching them in the right way and
Yeah.
ensuring that you're not stigmatizing people, because I think people can feel quite stigmatized. Anybody, if they've got struggling with their oral health, can feel quite embarrassed about talking or,
Mm.
speaking. Um, so I think it's really important that people aren't stigmatized or made to feel that it's in any way their fault.
Thanks, Emily. Really interesting.
Yeah.
Hi, Emily. Thank you for that. You mentioned, so you probably know I'm one of the lecturers in the mental health nursing in Bangor.
Yeah.
You mentioned that there's been some work done for well, both ways, but I'm interested in
Yes.
the oral health for nurses. Could you tell me a bit more about that, please?
Yes, there were some colleagues, a colleague in America in the US has done quite a bit of work around this. And if you want me to put you in touch with the colleagues, then I can put you in touch with them. So they've developed, um, I can't remember now which one's being rolled out, because I can't remember whether it's the dental health professional one, the education about mental health that's being rolled out in some institutions, or whether it's the mental health one that's being rolled out. But because there's a crossover between the people who are
Mm.
doing them, but it's definitely been developed, and it's ready to trial if you're interested.
Yeah, definitely. If I could have more info, that'd be great.
Yeah, I'll put you in touch with the colleagues who've developed it, and then you can have some more information about it, because I think it's a really good thing.
Mm.
Because it's not like trying to train people up. It's just so that people have got a brief understanding and knowledge to mention oral
Yeah.
health.
Yeah. It's similar, I suppose it's similar when you're giving any kind of health information, sometimes your own knowledge, or maybe you yourself have dental problems, or no dentist, or
Yeah,
many of them
yeah,
have phobias of dentists as
yes,
well. So it's just, yeah, unpacking that a little bit, isn't it? Yeah, thank you.
yeah, yeah, and that's what it is. It's just about, brief, just to give people that bit of confidence to
Mm.
initiate a conversation and understand a bit more that oral health is really important in a more holistic way. Karen.
Hey, hi Emily. It was really a very thoughtful session, and I just have one question. My question is why there is a mental health care pro means mental health professional who is conducting an interview.
Oh, sorry, why at the end of the study, or why is it a mental health professional who's speaking to the patient? Yeah.
Means the appropriate option is to
Oh.
choose a dental health professional.
Yes. So, in this piece of work that we're doing, this part of it is the mental health professional talking to the patient about their oral health. And the reason for that is people, as Nia alluded to, people can be a bit nervous about oral health or have, some concerns. So it was about a trusted practitioner talking to the person first, somebody that they knew and who understood. So whenever all the work that I've done around the physical health of people with severe mental ill health, people have said that they want to talk to somebody who understands the particular challenges they face and the challenges they face because of their mental health. And so that's why the mental health professional initiates the discussion. And then the second piece of work that we want to do is around dental health professionals coming to a mental health setting and giving some more oral health advice. So that would be some more I suppose I'm not quite sure of the quite word, hardcore is not the right word, but you know what I mean, like more sort of in-depth advice, I suppose. So this is just like a really light touch intervention that a mental health professional can give and be confident to give and feel okay with. So they're not trying to, and they're not going to do any oral examinations or anything like that. But if somebody did need to go to a dentist, then part of the intervention is trying to help them get support with going to a dentist, but we do recognise that it's really difficult currently in going to a dentist. So that's why the idea of bringing a dental health professional to a mental health setting is the next stage of that research as well. But that piece of work hasn't got so far yet. We've done some feasibility in terms of conducting some workshops and discussing it, but that's what we want to do next and apply for funding for next.
Okay, thank you.
Okay, so we're coming up to 1 o'clock, and I know people have got meetings to go to. So I wanted to say thank you very much for joining us again for this seminar. Please do get in touch directly with Emily if you have any more questions. And you can see all Emily's publications on her Bangor University profile page as well. And thank you very much, Emily, for giving this seminar. We've got another one next month, which will be Louise Prendergast talking about end-of-life care, and that's on the 21st of May. So hopefully see you there as well.
Thank you.
Thank you.